In this video, I am going to walk you through specific procedures using the extension principle following McKenzie treatment methods. All procedures are performed while continually monitoring patients' symptomatic responses to repeated end range movement and positional strategies. Start with postural education demonstrating proper sitting with lumbar roll. Patient sits at the edge of a chair, maintaining her spine in an upright position. She then scoots back and places the lumbar roll at bed line to passively support the lumbar spine in neutral position. This also places the cervical spine in neutral position given the absence of structural deformities. Let's start with neck retraction in sitting. This technique extends the lower cervical spine while flexes the upper cervical segments. Her jaw glides posteriorly on a plane that is parallel to the floor. Her range of motion increases progressively, reaching closer to end range. Neck retraction in sitting with overpressure. This technique is a progression to the previous one, where the patient applies overpressure at end range using her own fingers and respecting the same plane of movement. Patients should be guided throughout this exercise, as it is not uncommon to deviate from the horizontal plane with backward or forward tilt of the head. Sitting retraction with therapist overpressure. This one is a therapist-generated force technique. Clinician places one hand at the base of the patient's neck at about the level of the first or second thoracic vertebra to provide stability for the overpressure. Then, with the other hand, gently but firmly apply pressure against the patient's clenched jaw so that the head and neck is retracted as far as can be tolerated. Ensure that the patient's teeth are approximated so that the movement occurs at the spine and not the jaw. The patient should continue with the application of reductive pressures with patient-generated forces as part of a home exercise program. Patients with painful TMJs may benefit from applying the force with a mobilizing hand on the maxilla. Sitting retraction extension, progression to patient overpressure. This technique can be performed without support, with hand support, or with towel support. If the patient performs this exercise without support, she progresses from retraction to extension. She is going into end range retraction before moving into extension by tilting her head backward. However, these two components of retraction and extension are performed seamlessly. In the last few repetitions, she is wiggling her head with a small side-to-side oscillations at end range using the weight of her head to apply overpressure. No hand overpressure is recommended in this position. Sitting retraction extension with hand support. In certain patients who may be apprehensive to look up, ask him or her to support the neck as shown in this video during extension. This support should be discontinued as the patient reaches end range and progresses with side-to-side oscillations as demonstrated previously. Sitting retraction extension with towel support and progression to patient overpressure. Due to limited range of motion or other conditions, patient may benefit from using a towel to unload the cervical spine in this position. Observe how the support is released, allowing overpressure at end range with small oscillations. She then passively returns to neutral position using the towel. Retraction in lying, head supported on treatment table. If patient is unable to tolerate retraction movement in sitting or standing, which is a loaded position, then we should try retraction in lying. The head is supported while the patient actively retracts her neck. You can use a pillow or a towel roll under the occiput, monitoring that retraction occurs in the correct plane as previously discussed with sitting. Retraction extension in lying, progression to patient overpressure. If patient can now tolerate retraction in this unloaded position, we can progress to neck retraction extension in lying. She slides up on the table so that her head is off table to about T5 level, so patient is about 5 inches off table. Supporting her head with one hand, she moves from the end range retraction to extension in a seamless movement, getting closer and closer to end range with each repetition. In the last few repetitions, patient is instructed to apply overpressure by simply moving the head in small side-to-side oscillations. Head is not supported, but hands stay closer to return head to retracted position. This is a passive movement, and patients should not actively return head to the retracted position. Retraction in lying with therapist overpressure. The patient lies supine. Clinician supports the head behind the patient's occiput and moves off the end of the treatment table so that the head, neck, and shoulders are down to the level of the fifth thoracic vertebra. The clinician stands to one side and supports the occiput with one hand. The thumb and fingers of the other hand are placed over the patient's upper lip or mandible depending on comfort. The head of the patient is held gently but firmly against the clinician's waist. The patient retracts to end range, and at the end of each movement, overpressure is applied by the clinician. The head is then returned to the neutral position. It is important to ensure that the patient's head is kept in the horizontal plane. Traction, retraction, and extension with rotation mobilization. The therapist passively performing traction, retraction, extension with rotation mobilization achieves a progression from the previous patient-generated force technique to this therapist-generated force technique. He cradles the patient's head with the dominant arm and places his index finger in front of the patient's chin and the middle finger underneath it. All other fingers are loose to avoid pressure on the patient's anterior neck. The opposite hand supports the occiput, resting the first web space along the superior nuchal line. The first component of this technique, as indicated by its denomination, is traction, followed by retraction. Once retraction reaches its maximum, therapist moves the patient's neck toward extension, while maintaining traction and retraction. After several repetitions, and while monitoring patient's response to repeated movements, therapist applies rotation mobilization at end range using small side-to-side oscillations while progressively taking the patient's neck into further extension. The return to neutral position of the cervical spine is done passively by reversing the order of all components. Make sure that traction is maintained throughout the range until the neutral position is reached.